Welcome, everyone, to today's webinar, Healthcare in 2023 and Beyond, a Financial Outlook for Revenue Leaders. On behalf of Becker's Healthcare, thanks for joining us today. With that, I am pleased to introduce today's speakers, Jonathan Wick, Vice President of Healthcare Insights, FinThrive, and we have Tony Bayman, Director of System Patient Access and Training at Memorial Hermann Healthcare System. Jonathan and Tony, thank you so much for being here today. I'm going to turn the floor over to you to get us started.
Thank you so much, and thank you, all of you. Happy President's Day. Tony and I were talking hospitals stop for no one, and I figure lots of you are probably at work having a lunch and learn today. I remember, I think our hospital, when I was managing our revenue cycle, had 6 holidays that we all scrambled over in leadership, but that was about it. And I've worked my fair share of Christmases and New Year's. I loved it because I got free lunch at the hospital. I'm on those days. I hope that rule still applies. And when I was getting paid hourly, I was getting paid time and a half. So we'll dive in here. I'm going to start, and then I'll have Tony kind of dive into her section about halfway through here. I'm going to start with a poll question here, and let's go ahead and answer. Tony and I are interested, while we're talking to you today, on what your strategic priorities or objectives are this year. FinThrive looked at these 5 things and have already surveyed about 80 executives, 80, in the market. And I want to validate if that survey was a good sample with you all. So that should come up here in a minute, I think. They'll launch it for us, and we'll show you the results here in just a minute. But go ahead and pick one of those. And, you know, I realize these are probably hard. You know, you're probably working on all 5 of them. But I used to tell my CFO, you know, I have 1 fire truck and 1 hose. I can only put out 1 fire at a time. What fire, you know, is it? If you only had to pick one, try to pick one of those. And we'll give it a few more seconds here. Looks like only about a third of you have answered. So staffing, I've heard quite a bit, although I think that's starting to ebb back a little bit, that tsunami of labor shortages. I think it hit the clinical side a little more than it did the financial. We all want more money. I wouldn't be surprised if that comes. I think cost reduction is gonna be in the top. We'll see. Patient experience, I've seen go up and down. It used to be number 1 for quite a while. Then the C word happened, not cancer, but COVID. And I think that caused some of that to slip. And payer-provider collaboration, you know, I don't think that's going to end up very high. But we'll see. I don't mean to skew you guys. We got about half of you, so I'm going to go ahead and show those results. Yeah, there we are. And those almost fell exactly the way I thought they would. Provider-payer collaboration, about 14% of you actually put that above patient experience. I'm impressed that patient experience is actually running last there, but that's important. And I think, you know, I'm going to write those down too. And I think the folks at Becker's too can help me. I love taking screenshots of that stuff. So if one of you guys can grab those answers for me, that'd be awesome. But that's good. And, you know, I think cash is king. You're going to hear that a lot from Tony and I today. It's one of her goals. I think you're always reducing costs, and you can't do it if you don't have the people or the technology to do it. And then hopefully those other things kind of happen. And we'll see where we end up. Let's dive in here. As far as, you know, where we're at, I wanted to give you an update on what's going on in the healthcare market right now and give you some insights into 2023. I'm going to talk about the public health emergency a little bit. And then Tony is going to talk about what specifically they're doing at Memorial Hermann. And she's got some great slides and some exciting things. She is passionate, almost as passionate as she is about motorcycles. She's as passionate about her team and training them to make a difference with every single patient encounter financially and driving that in the organization. You're going to see some best in practice metrics from her and what her team's up to. And I'm going to kind of set the stage as to why hospitals need to be doing a lot more things like Memorial Hermann is going into 2023. Let's talk about volumes first. At FinThrive, we've been tracking data since before the pandemic. If you were to look at the left side of that, I realize this looks like a patient in VTAC, those clinicians on the phone. Excuse me, but on the left there, where, you know, you see kind of that tight horsetail, if you will. If you were to go back, you know, 3-4 years into 19 and 18, you would see that there'd be some seasonality, you know, over the holidays and things. But for the most part, volumes, you know, never really went below 5% or above maybe 10%, depending on the month. We were having a very, very good Q1 before COVID happened. And then, we all remember what happened in March. And the Surgeon General helped or didn't help, depending on your perspective, by turning off all elective procedures to, stop the spread, bend the curve, save supplies, all that fun stuff. So you see that trough, respectively, in inpatient, emergency department, outpatient visits. And then we slowly recovered. And then Omicron happened to there about middle of the graph. We saw more volatility, then some stability this year. But what I think is most important to point out is that horizontal line is normal compared to what things were like pre-pandemic. We, for the most part, as an industry, at least in the hospital area, have not seen volumes recover consistently. They've came back a little bit on the outpatient side and have certainly recovered, from the low 20% down in the ED and inpatient side to the low 10s. But as you can see on the right there, ED and inpatient are down significantly. Outpatient's about normal. I'm using that term loosely. My point with that is I don't think as a hospital you're ever going to get some of that volume back. I think the macroeconomic shift, the lifestyle shift, the coverage shifts, the employment shifts, the work from homes, all the things that happened has really caused, and I'm going to say the word, I promise I'll only say it once, unprecedented change in our market in that consumers, I'm not even going to call them patients, consumers have figured out a new care model. And that might be good or bad. The bad of that would be they don't go to the hospital as much as they used to anymore, or they wait it out. The good of that might be telehealth. And we're monitoring that very closely as well. And maybe they're substituting that, and lots of these emergency department visits that occurred have maybe transitioned into something that's more subacute. The point with all of that is hospitals' operations and financial viability has been based on or predicated on some sort of predictive volume, right? We have this many nurses and this many techs and this many registrars, this many schedulers based off how much patient volume we have, be that on a floor with nurse to patient ratios, in an ED with how many ED beds, how many outpatient surgeries you're doing, how many phone calls get made, so on and so forth. And I think it's kind of been this elastic kind of nastiness that's been occurring with volumes over the last few months, if not years. And you could spin a wheel right now. I think it's tough. So a lot of you might be in hiring freezes. You might have some labor issues, some other things going on. And I think it's going to get a little better in 2023 from a stabilization standpoint. But I think it's important to understand that if you're staffing for what you once did in 2020, those patients aren't going to support that level of staffing. You're going to have to become more efficient through technology and other things moving forward. Speaking of moving forward, when you have poor volumes, you have poor margin, and their labor expense as well. We'll get into that in a minute. But Kaufman Hall flash reports, one of the few things that are FREE free in healthcare. I encourage you to go out and get the Kaufman Hall flash report. I know Ken Kaufman does a great job. There's about 6 pages of data behind this. But we saw 12 months of negative margins occur. If you went back to December of 21, that was negative as well. And we just saw daylight in December. The January report's going to come out this week, and I anticipate that to be positive as well. We'll see, but usually the beginning of the year is better than the end of the year. We'll see where we end up. Kaufman Hall expanded a little bit and went into, the two big foundational reasons of why volumes and margins and expenses were all related are here. We had 19% year over year increases in labor, which impacted FTEs over AOB, or adjusted occupied bed. That's the number our hospital tracked, and that is great to have that variant, but it got outweighed by how much we were paying premium traveling nursing, premium traveling techs, and others. It wasn't so impactful to revenue cycle, but it did kind of trickle down. Like if revenue cycle needed to hire somebody, they couldn't because the whole organization was on a freeze, for example. And then the volumes I talked about, and you see that primarily inpatient and ED. So that volume that we've been tracking from our customer base is also being echoed here by Kaufman Hall. As you look at those things coming together, Fitch amplified this deteriorating rating. They changed their rating from negative to deteriorating. And I did highlight just a few things that they talked about here in that report. It's fascinating to go read if you'd like it. It came out in December. But labor pressures and inflation compressed margins, highly pronounced in a very short period of time. I think we saw a spike there. That was compounded by poor performance in the markets. Hospitals invest and health systems invest just like you and I do in our 401ks. And 2023 is not expected to show a rapid operational recovery. And I circled that. I think that's what's important is we're not going to just snap back. And if you've worked in healthcare long enough, you know that it's an aircraft carrier. It takes a quarter mile to turn it around. So I think we're going to see recovery, but we're not going to feel all warm and fuzzy until about probably summer, spring, if I had to guess. It's going to be a bumpy, a bumpy spring, I think, and into the summer, maybe fall. We may start coming out, depending on how good or bad you were doing before this happened. A few select health systems will continue to enjoy strong operating margins. Those that had a lot of cash on hand and actually weathered the storm well, maybe exited the markets a little bit, managed their staffing and were staffed pretty lean, are going to be, kind of the exception, not the rule as we move forward. Labor, I always like pointing out this survey. This is the JOLT survey. This is the job opening turnover survey from the Bureau of Labor Statistics. I love following this stuff. I'm a nerd. It's great. And I just want to walk you through this graph. It goes back to 18. Again, similar as I was talking to the volumes, if you were to go back to 2010, pretty much same pattern that you're seeing up to 2020 there. There's always going to be a little gap between how many people you're hiring and how many positions are posted, right? That's just the nature of healthcare, especially. There's always more positions posted than what you can hire. It's a catch-up mode. But what happened with COVID, you saw that spike in kind of volatility, and then there's this bifurcation or divergence, right? And it's huge. There are 2 million open positions right now. So even if you could hire everybody that you wanted, just between HR, candidates coming in, job competition, and unemployment's very, very low right now. It is hard to get people to work and stay within your organization. I've talked to several leaders. Neovis Kiro out in Mass General out on the East Coast says, they're competing for fast food restaurants in her area, and they can't pay their folks enough in that area to afford a 2-bedroom apartment. And I hear that from lots of leaders. So it's really important to look at who your staffing is and where they're at, especially in revenue management, so you can understand how you keep them. Because I don't know that you're going to get them necessarily. So you're going to have to really leverage the folks that you have and where you're at. And Tony's going to go into some of the strategies they've done at her organization to help with that. If you don't, this is the poop that's going to hit the blades, for lack of a better way of putting it. You're going to see these things happen. These things already happen at your organizations, but they absolutely are going to magnify when you don't have enough people or processes in place enabled through technology to manage them effectively. Billing errors are going to occur, and we all know what happens with that, right? That just creates rework, and your team is not staffed to resubmit bills. They're staffed to submit bills. You don't have people sitting on a shelf that you pull off to say, hey, we got a bunch of rejects. We got to go work them now. That's not usually part of a run rate for staffing. Hold times in your CRM centers. Cancels and reschedules because of all the staffing constraints that are happening. That impacts your department in revenue management because you're the ones that are scheduling them. Price transparency compliance. I've talked to several very large organizations that said, you know what, it'd be great to fully comply with No Surprises Act and transparency. That's a nice to have right now, not a need to have. I'm just working on staying afloat and managing it. I disagree with certain provisions of the rule they've told me. I do as well. I think the intention's good. It's just poorly deployed. And then operational deficiencies that are occurring because of the labor shortage as well, just things that you'd like to do that you can't. A letter from 25 state governors came to end the PHE. I'm going to transition into the public health emergency here in a minute because I've gotten a lot of questions from my colleagues in the market and others about what's happening with the PHE. I'm happy to do another talk on PHE for your organization if you need me to, or through HFMA and your local chapters or those types of things. I've been studying it profusely to find out. But the fact of the matter is that the state governments, most of them anyway, have said, look, we've got to figure out how to manage our budgets, and we can't just have this thing end and then continue to fund for the rest of the year all these enrollees. We've been doing this month to month before COVID happened. I get that we had to kind of put these lifeboats in place while it was happening, but we're kind of over it now. We're moving forward. The other half is either quiet or thinks the PHE is a good thing. I'm not sure where they're at. My point is that there's a lot of pressure to have it go away. When it goes away, there's about 15 million folks that are going to have an impact. And I want to take a minute and talk about churn. And I realize that's fine print down there below, but you can go to this ASPE website, their division of the HHS, the Health and Human Services. They do research. I think this is the most accurate analysis of public health emergency Medicaid impact that I've seen. And you got to think of it like a wedge of 15 million. And about half of that wedge, roughly, about 8 million of it, a little bit more than half, about 60%, are going to just not be eligible for Medicaid anymore. They got in during some sort of waiver process that the states put. They would have been disenrolled because their income increased, or they got married, or have eligibility under some other type of provision. They're going to leave. You all know what's going on with those. That's what you did before COVID. And your churn rate probably was about that. Probably was about 10%. Every month you probably disenrolled about 10% of the folks from Medicaid. On the other side, you have this churn or this administrative churning that's going on that's causing a error to occur when folks think they can enroll, but in fact don't. And this is, the story you hear from CHIP and all those other, the Children's Health Insurance Program. They feel that they aren't eligible, even though they are. And this is where there's really a big opportunity to do outreach, because per Kaiser Family Foundation, only 10% re-enroll in Medicaid once disenrolled within a year. And that number goes way down in 90, 180 days. So there's going to be a significant shift from Medicaid to either self-pay or the exchange plans or the ACA or Obamacare plans, depending on what you'd like to call them, the brokerages that are out there. So much so you saw the government, and I wasn't even expecting this, a special enrollment period to come and happen. What I wanted to kind of give you some background, you've done this. You know how to do redeterminations and the continuous enrollment requirements that existed before COVID happened. You've done it for decades. Run it every month, see if the people still enroll. If they don't, try to get them on some kind of plan or your charity or find some other source of coverage, right? PHE happened because of COVID. That froze everything to the tune of 20 million more people getting onto Medicaid. And then they came up with a rule, the omnibus rule, the Consolidation Appropriations Act that just got passed last year, that says, hey, April 1, regardless of whether the PHE is going to get removed, which I think it absolutely will here, April 14th. But they, it's weird the government's actually doing right and left-hand stuff together here. Said, hey, you're going to be able to cascade or phase out these enrollments, and we'll keep the FMAP going for you. We're going to keep this 6.2% into March, when we're already in this period now, gang. We're going to keep it 5% into June, 2.5% September. They've actually put it out there. We'll keep paying a little bit more matching to the states while you're disenrolling. And in the appendix, there's a slide that talks about this, or if I didn't put it in the appendix, I certainly could send it. But my point is that this is coming, and it's a really big deal. And as it's coming, we need to look at what are those things that are causing it, where are we at, and what are you doing from a people, process, and technology standpoint to ensure folks have coverage? Because you know what happens when there's not a funding mechanism. People are afraid to go to the hospital or afraid to go to the clinic because of the cost. And they're also afraid of lots of other things right now. So this is very, very important that you get your state's plan. Every state's going to have a different plan. It's required by the federal government to have a plan already. And I'm happy to put those resources in front of you if you're in a specific state. But understand what the state's plan is, what your team's plan is, and whether you're insourcing, outsourcing, or leveraging technology like FinThrive to help find that coverage or eligibility or financial aid or getting into Medicaid applications, whatever that is, figure it out, because it's about 1 in 5 Medicaid enrollees are going to be impacted by this. Now, they may be positively or negative impacted, like I talked about. We're to our second poll question here, so let's go ahead and answer this. How prepared do you think you are for the public health emergency? I'm interested to see if you're all just kicking butt and you're better than 75%, given that it's coming up here in 2 months or not, go ahead and answer one of these, and I'm going to turn it over to Tony here, and she's going to dive into her stuff. But, what level of preparedness do you think you are or your organization's at? I didn't put a don't know. If you don't know, then guess. Because I hate it when people say they don't know because it doesn't help this audience out. But let me know. I only got about 5% of you answering here. There's 16. Let's keep going. I want to get it to about 30 or 40. And I put answers here, and, I don't know where you guys are going to end up here. I've talked to folks. I think some are really ready, some aren't. We might get a mixed bag. We'll see where we end up here out of the 200 or so of you that are on this webinar today. But, if you're not ready, get ready, I guess, is my point. And you've done this before. You're just going to have to dust off what you were doing back in 2019 and early 2020 with your Medicaid re-enrollment. You may not have those people anymore. You may not have that technology or business partner anymore. Who knows? There's about half of you answering now, so I'm going to go ahead and cook on over. Interesting. So there's a large percentage there in the middle that feel they're somewhat or moderately prepared. It's about half of you, but there's about 10% of you that said, we're not ready. We don't know what we're going to do. And good for you. The 8% there at the bottom feel like you're fully prepared or ready to rock and roll. Again, reach out to me. I'll be back at the end here with Tony as we kind of summarize what she's going to do at Memorial Hermann. But it is my distinct pleasure to introduce you and let you hear from an expert in her field at Memorial Hermann about patient access. But she's going to tell you what's going on at Memorial Hermann. Go ahead, Tony, take it away.
Well, howdy and yeehaw from deep in the heart of Texas. And thanks, Jonathan, for all of the information that you shared. Your energy is absolutely contagious. So I'm going to talk just a little bit high level about Memorial Hermann. Memorial Hermann is one of the largest not-for-profit health systems in the Southeast Texas area, and we've been serving our community for over 115 years. Next is just our mission, our vision, and our values. Really, it's about caring for our patients and their future generations in all areas of our community. Just a few nationally recognized services. I'm sure it's a lot of the services that you guys provide at your facilities as well. And now I'm going to just share a few numbers. We have in fiscal year 22, about 1.7 million patient encounters, lots of people that we were treating. We have over 29,000 employees, over 260 sites for our care, and we contributed about $474 million to our community. And I'm just super proud to work here at Memorial Hermann for sure. I think it's an amazing organization, and really proud to work in healthcare. I don't know of a better place that you can work where you really take care of your community, whether you're on the clinical side or the financial side. It's an amazing opportunity to help. Okay, so our priorities in the revenue cycle management space is cash, which I'm like Captain Obvious, right? I mean, everybody is focused on cash and how can we impact operations, right? While we are also this year going to be implementing a new EHR in spite of all those challenges that Jonathan's talked about. So the operational challenges of, being short-staffed, payer issues that we have. I think we all experience those issues with delays and denials and underpaids. And then really ensuring quality on the operational side, on the financial side, to ensure that we've captured all the revenue, that we've captured information accurately, we've reduced our unbill, we're sending out clean claims, some of the stuff that Jonathan talked about in that quality section as well. Next thing I want to talk a little bit about financial clearance, and really this is about financial care. So we know that we provide excellent clinical care and our patients have good outcomes, but really they'll have better outcomes with our financial care model as we help them on this journey, right? It's critical that that care goes hand in hand to reduce their anxiety and actually help them heal better. So part of what we do in the financial clearance space is really partnering with our patients, kind of advocating for them, walking them through this thing that we call patient access, helping them to find the right care, helping them understand all of the questions that they have about what they're going to owe, reducing, again, that anxiety. We also verify benefits. We use a lot of different tools in order to do that. We have real-time eligibility embedded in our systems. We use batch eligibility, portals, and even just old-fashioned phone calls, right, for the payers that don't have information on their portals. We also ensure that we have authorization to try to reduce those denials, prevent denials. We try to dot every I, cross every T, record everything, document everything, capture information in our document imaging system to ensure that we can appeal any denial that may come later, and really creating that estimate for the patient, again, helping them in the decisions, helping them understand their benefit structure, the limitations of their benefits, in order to provide that financial care to them. And then contacting the patient, again, explaining everything to them. Also complying with that No Surprises Act mandate. That's a fun one that got thrown in. And then we also have a central pricing office where shoppers can reach out to us. They can call us, or we have information on our website where there's a shopper tool on our website. And then they can also reach out via our website if they have questions and they're trying to get a price estimate as well. So we've tried to kind of provide multiple options to our patients so that they can get the information that they need based on their preference. And then we also work status changes. So if a patient comes to the ER and gets admitted as an inpatient, we work those cases as well to make sure that we notify the payer, that we get authorization, we follow up on the authorization. Really, the thing with patient access is there is absolutely no tomorrow. There is only today. We have to get it right today in order to help our patients and to make sure that we protect the integrity of the organization. Next thing is just frictionless payment options for our patients. Again, we try to meet our patients where they want to be met, so providing multiple options. If they want to talk to us, we'll talk to them. If they want to pay online, we also have a mobile-enabled option. Patients can actually set up their payment plans. We have some guardrails built in the system around that, but they can actually set up their own payment plans. We offer some financing for certain services. We also offer some limited package pricing for a particular service line that includes the hospital, physician, and others in the care team. And then we also have a vendor partner that helps us with this as well. Again, it's about that financial care model and how can we help patients and provide options that would be easy for them. Next thing is HCAHPS. I'm sure all of you guys are looking at HCAHPS. You can kind of see here that this is something that we track, and definitely we measure this and we talk about it. It's a focus for us. Definitely, we're pretty disciplined in our approach to this. You can also see that it's a little bit of a challenge sometimes to maintain those scores, but we do focus on that and are constantly looking for ways to improve those outcomes and those scores. We also recently implemented a new survey tool to track NPS, and that goes hand in hand with our Memorial Hermann experience, where we've trained about 29,000 people in our organization on our service standards and how we meet those service standards to take care of our patients. Again, just a kind of a summary of the HCAHPS surveys. You can see it's really difficult to consistently have high scores. We dip and then we kind of come back up, but we do know that patients will heal better. They will feel better about our organization when they understand their financial responsibility, which is why we try to have so many different options for them in determining what they owe, helping them with payment plans, self-service, various options that would help them in that space. Next thing is our point of service cash collections, which is we do really well in this space. We have really strong upfront cash collections because, again, we try to provide that financial care prior to the patients arriving for service as close to the time that they're actually scheduled for the service as possible to help them have a runway in order to get the money that they're going to owe us up front, to understand why they owe that much, to give them an estimate that is really thorough and accurate. And so we have really strong cash collections. It tanked a little bit in COVID, which was understandable, and some of that was very intentional and our strategy to try to help patients through that difficult time, many of whom had lost their jobs, and we tried to provide some additional options and some runway to pay after the time of their service. I am happy to report for January of 2023, we're at 2.14% net revenue for our cash collections from their patients. So we're having a good month. Just lessons learned as we've been on this journey is it really is harder than you think. It really does take longer than you anticipate. So we've implemented a lot of different tools for our patients, online, various vendors that we've partnered with to really provide service in various ways that would make it easy for our patients. And sometimes that takes longer than you think. Really the adoption to try to reach out to patients, really reaching out to our physician partners as well so that they can help in communicating that to their patients, our patients, so that they can know what to expect. And so sometimes that takes longer to get people to adopt and to make sure that they understand the options and to work through those various issues. Also, selecting that right vendor is obviously critical, specifically with RPA. We are continuing to kind of expand and look for opportunities as that technology has matured. Anything that we can do to try to create some efficiency on our side with our team, especially given the short staff issues, so that we can actually spend more time with the patient. So my take is that I want as much technology as possible, and I want to reach patients where they want to be reached. So I'm all into using my phone and doing everything online, but my 98-year-old mother-in-law isn't, and so she wants to talk to somebody, and so I want to use technology to reach people the way they want to be reached, and then also to give that personal touch for the people that do not want to use that technology so that, again, we can kind of hold their hand and walk them through the process. The other thing is just, fail quickly. I know sometimes we keep trying to make something work, right? We had an idea and we thought it was going to work. We maybe even bought some software that would support it or developed some software that would support it, and it's not working, but we just keep trying to make it work. And so I think it's important to just fail quickly and then to move forward, kind of think about what went well, what could have been better, what were the gaps, what were the things that didn't work, and what can we do to learn from that and move forward so that we can gain some capacity and make the necessary improvements. All right, I think we are ready for another poll. So what area of the revenue cycle is the focus for you? So Jonathan's put this poll together, and patient payments, patient intake and scheduling, financial clearance, kind of regulatory, or improve payer-provider collaboration. Kind of what is the focus for your area? Okay, I can slowly see people are starting to respond. Thank you. We're anxious to hear your opinion. Okay, almost 50% have completed the poll, so look at what the answers were. 20% definitely patient payments. The highest is improved payer-provider collaboration. I agree with that. A lot of our challenges are definitely with the payers and requirements and meeting all the mandates, so that is an excellent one. I would love to hear some suggestions on what you guys are doing in that space, because I agree that would make a big difference in the entire revenue cycle. All right, Jonathan.
Thanks, Tony. Beautifully presented as expected. That's great stuff. We're going to kind of dive into, giving a summary of what I and Tony talked about here, and then we'll open it up. We've got plenty of time for questions. We screamed through that material for you, but we really wanted to have a dialogue with you. I see 5 or 6 questions in the chat while we're summarizing here. Think about stuff you didn't see. As Tony suggested, think about if you were the one that answered payer-provider collaboration, put that comment into the Q&A, and say, hey, we're doing this as anybody else, and we certainly could monitor that and see where we're at. And I certainly can give my perspective on what I'm hearing in the market as well about payers and providers and where we're at. I saw this quote, and I thought it was really good. And I'm not a cliche guy per se, but I love this. And I don't know Lisa, I know Ken, but she sounds like a brilliant lady to me. She's an SVP over there at Kaufman Hall, and she said this is like changing a tire on a race car going around the track. I watched a little bit of the Daytona 500 yesterday. It's just hard to manage near-term versus long-term, and things are moving very fast. You heard Tony talk about failing fast and trying different things and making sure that they've got, good processes in place that's foundational, that are, I would argue, agile or flexible to what's going on. When Tony and I were preparing for this, the poor thing, she's getting hammered, for lack of a better word, from all the different things in the organization that impact patient access. And patient access really is a big pipe. It's a funnel. I used to say when I worked in my revenue cycle, nursing may only touch their clinical vertical, right? Patient access touches everybody. Revenue management touches every single patient. Every single one is getting talked to at scheduling or when they come into the building. And certainly, it may not be verbal, but they're getting some sort of statement or bill at the end. Every single one. People say that a lot of, not that nurses aren't important or physicians, but they're seeing a subset of the patient base where revenue management is seeing all of it. So it's a very, very critical time right now. It's super important to make sure that you've got a good pit crew and you're managing, the patients as they're coming through and making them feel like you got them. You're advocating for them. You're helping them navigate their care and coverage, like Tony talked about at Memorial, and that you're really, helping them get filled back up with gas, putting on new tires, and helping them focus on what's most important and getting better, and not worrying about all these other things that are going on. The driver's not worried about their tires or their gas. They're worried about their race, right? And the hospital's that pit crew. It's kind of a bad example, but my point with that is that it's moving very quickly right now. And I'll say it again, it's super important with things moving quickly to slow yourself down and really take an inventory about where you're at and what you're doing from a revenue management standpoint so you don't miss anything. I get this question a lot, and then we'll dive in here to a summary and then open it up for questions. But, what's 2023 going to look like, Jonathan? Where are we at? So I stayed with the tire theme and put this together, and I'll kind of start up there at 12 o'clock at the top. You saw it at the beginning of this deck, 12 months of negative margin. You don't have to be a finance major to understand that that's got to be made back. And I think how you make it back is going to be important, right? Are you going to try to make that back through inpatient and ED, or are you going to function as more of an ambulatory type reach out as you move forward? That'll be important. Those volumes closely relate to that over there at 2 o'clock, right? Are we enhancing or reinforcing patient loyalty? You saw all the things that Tony and her organization are doing. They are very patient-centered and focused about financial care. I love that term, financial care. I think that's great. It's just as important as clinical care. What are those things so you don't have to worry about them, so you can focus on getting better? We've got your bill. Let's figure out what that's going to look like and find coverage mechanisms and funding and payment mechanisms for you that fit where you're at, and they meet each patient where they're at. Borrowing power and expense, I'm not going to spend a lot of time on that, but with inflation and things, hospitals have to borrow money just like anybody else. And you saw from Fitch that deteriorating rating. I've heard a lot of CFOs say, look, we've got to keep our AA rating so we're not having a higher borrowing expense. We'll follow that through as we go. Cost reduction, it ranked, number 2 in the things that you ranked at the top, so that's there for sure. I think you all are in cost reduction mode. My hospital used to have a any which way you can model. Let's come up with $1 million, $2 million. I don't care if you do it through labor, vendor reconcessions, or consolidations, and maybe going towards an end-to-end, and instead of having 26 systems, having one really good system that kind of checks a lot of those boxes. Labor, as I mentioned, over there at 5 o'clock or at 8 o'clock, it's kind of is leveling off. And then strategic planning, and strategic planning really is being shadowed right now. I think that's something like we talked about, where you're seeing CapEx and OpEx budgets probably being frozen, if I had to guess. And I'm not sure what Maurel Herman's experience is, but I would argue things are probably slowing down, especially if there's an Epic conversion and others. They don't want any distractions, right? And we don't want any distractions. And with the declining margin and declining patient volumes, that seems to be where we're at for the year. Tony and I are going to walk through these. I'm going to take 1 and 2. She's going to take 3 and 4 here. But I think in summary, and then we'll open it up for questions here, market headwinds forecast a year of recovery. So you saw the deficit, you saw the volatile volumes, you saw my predictive year and all those things that are causing it. I think you're going to have a bumpy spring, maybe a leveling summer, and probably a bright fall, if I had to guess. And I just think that's what you see in hospitals, kind of this ebb and flow in health systems as we go, and that's where we're going to end up. Cash is king. You heard Tony say it. You heard me say it. You're going to hear your CFO say it. A lot of focus. I was just out at the Southeastern Summit. They did a great job out there in Atlanta. Heard from a CFO panel, a revenue management panel, several experts, and every single one of them talked about the importance of days cash on hand, maximizing reimbursement from payers, maximizing reimbursement from patients, or patient payments. It really isn't reimbursement, right? But really focusing on that cash. And Tony, you had some thoughts on optimizing people, process, and technology, and how that's worked in your area. Do you want to share on that?
Sure, Jonathan. Thank you. We are looking for every possible way to become more efficient through automation, and then really serve the patient. So allowing them to schedule their own appointments and services, doing online forms prior to them showing up so that the clinician has what they need, doing consents online, and then really texting patients with their reminders, doing all sorts of things to try to help them navigate the experience in patient access and in the revenue cycle. And we're looking definitely to expand some of those offerings. Can we add more services to that suite to give them even more options for finding service, really to fill the gaps in the service especially. And then, Jonathan, you mentioned here having a foundational revenue management strategy. Really, it's those core metrics, the discipline and the focus to measure those outcomes, and then adjusting as necessary with cash and upfront collections and unbilled and all the metrics that we have. We are definitely metric heavy in the revenue cycle, and then just focusing on any gaps that we have and putting processes in place to address those.
That's awesome.
Quickly.
Yeah, quickly. That's right. Always quickly. There's no tomorrow in patient access,
yes,
right?
Absolutely.
Cool. I think we're going to dive into questions. I've been looking at them a little bit while Tony was talking, and Tony, you're welcome to go peek at them too and pick out some of your faves. But I think the moderators or Paige, I think, is going to just kind of start hammering us, and we'll answer them the best we can in the last 15 minutes, and we'll dive into the close. So Paige, how about us?
Yeah, sure. I'll try not to hammer too hard, but thank you, Jonathan and Tony, for the presentation today. At the risk of repeating ourselves too often, we are going to begin the question and answer session. So anyone listening in, please submit any questions you have by typing them into the Q&A chat box on your webinar console. So with that, I'm just going to go in and get started. First question I see here, what barriers exist to payment automation and putting hospitals on a nationwide interoperable network?
Ooh, that's a big question. I'll start with that one, Tony, and then you certainly could dive in. Yeah, I think, a nationwide interoperable network, that's a mouthful, right? You're going to hear from the Office of the National Coordinator, the Department of Health and Human Services. There's something out there called the Blue Button Initiative, if you haven't seen that, for Medicare, that talks about, the portability of the health record. There hasn't been a lot of talk about the portability of payments and like having a global payment. Where I've seen momentum in that area, if I'm answering your question right, is partnerships with payment companies, and they're all out there. The patient codes, the visit pays, the flywires, all of these ones that are out there. Even the banks are getting involved. The clear balances and the others that are there, care payments. I think what people want, and I've heard from many organizations like Banner and others, a way to where the funding of healthcare is better understood by the consumer, and Tony can certainly add to that with what they've been doing with estimates and their point of service collections. I think people understand what they pay, and the affordability is an issue, but that could be handled through financing. No one really that I'm aware of, unless you can, Tony, can afford a car with cash. It's rarely something that you're paying cash for. You're financing that. Healthcare is one of the few things that costs as much, if not more, than a car. That isn't, that much. And I think that's where that national area will look at. I don't think you'll ever see legislation for that. I think it's going to be very market driven. And I've seen innovative health systems have, financing and payment plans and things kind of all prearranged. I call that financial clearance. Even though, someone has insurance, that doesn't mean they can afford their cost share. But Tony, do you have things to add on that?
No, Jonathan, I think you touched on everything. That was really good. I think we could do more in the financing area.
Yeah,
again, I think we're kind of behind as an industry in that space. We do offer some, like I said. I think we are looking at trying to offer more, and then even just financial assistance, making that easier, et cetera, to kind of have the whole package.
I have another audience question for you both. Have you ever experienced payers requesting or mandating reference-based pricing? And to add on to that one, if so, how have you responded and how does it impact the revenue cycle?
Tony, have you touched that or are you aware? Go ahead.
Yeah, I am definitely aware, and we do have a strategy in that space, and we have some guidelines on that. Is we don't accept reference-based pricing plans unless the patient pays us the difference. So what we're trying to do is help the patient understand what kind of policy that they have, because it's truly not an insurance plan. We're not contracted with that insurance plan. Many of those are ministry-based, that sort of thing. And so we do a calculation as part of our upfront collections that we determine how the reference-based pricing plan is going to pay, typically at some percentage of Medicare, and then we calculate what we would expect from that payer based on some of our average managed care contract plans, and then we explain to the patient that they're going to owe that difference before they come in for service.
Gotcha. Someone else mentioned they would love to hear what other RCM metrics or KPIs MHHS uses to measure RCM performance. They said they're working on several issues within their health system, and leaders are struggling somewhat with defining this.
Tony, I think that's yours. What types of things you shared? Point of service collections, NPR. What other metrics are in front of you every day?
So we have a ton of them because we are metric heavy, which is good. But obviously, cash as a percent of net revenue, the cost to collect, unbilled days and dollars, denials. What are we doing in the denial prevention space? Underpayments and working with the payers, dispute resolution, employee engagement. Even that's an important part so that we can continue to provide that financial care to patients. But those are just some of the metrics that we literally look at every day to try to help work to improve and to keep that before all of our leadership.
Gotcha.
Cool.
Someone else mentioned a struggle within their own healthcare system. So someone said their biggest struggle continues to be Medicare Advantage. They're trying to improve communication and relationships with these payers, but it proves to be very time-consuming and frustrating for them. She said she's sure others are experiencing the same issues. Do you have any tips or information to share?
Yeah, I don't know if you're aware, and Tony will laugh at this, the government's trying to help. There's a bill out there, and I'm happy to pass it along at the end of this, that's being proposed by HHS and some other folks that is looking at interoperability and something called FHIR, which is a fancy word for interfaces or APIs, fast healthcare internet resources, I think is what FHIR stands for, and then application process interface. I don't want to throw too many technical things at you, but if you've ever had to pick up the phone and get a denial, or an authorization, it's typically a 30-minute phone call. I worked in an MRI department for quite a long time. And then, of course, it changes and you got to start all over again. You're seeing medical necessity denials, and there's been lots of studies and lots of media attention placed on the fact that when traditional Medicare has been signed over to Medicare Advantage, that health plan, which is also the fastest growing, by the way, has had 2x, 3x denial rates compared to that of Medicare. So you're not alone. I really appreciate the comment. What I've seen work, and then Tony, I'd be really interested to hear what you're saying, is identifying that. So I think, I worked for a payer too. I liked comparing myself to others, and I liked providers that did their homework and that would tell me that. So if I'm denying more than someone else down the street, I want to know that. So I would benchmark that data and make sure you've got similar pools of data, but say, hey, I saw this group of Medicare MRIs and your Medicare Advantage MRIs, and you guys are denying things 268% more. There's not a medical reason for that. And if you have appeals on that as well, and FinThrive has software that can help with that if you need it, but if your appeal overturn rate and those types of things, and when we go to appeal, you turn it back anyway. And I think that's a big frustration I'm hearing, is that folks, are fighting, and then they have to take it to appeal, and the ultimate win. Well, the payer and the provider just wasted each other's time for 2 or 3 months. Tony, do you have thoughts on Medicare Advantage? Are they driving you nuts out in Texas as well?
They are. The struggle is real.
Yeah.
So I ditto all the things that you've articulated, but also we really try to work with our managed care contracting team on meeting with the payers, drafting contract terms that would make sense to both of them for our side and their side of the business, because it's costly for us and it's costly for them too, right? But also we're looking at the appeal success. Again, if you're finally paying it when you could have paid it a long time ago, what could we have done to ensure that our payment was more timely and not have to go through the appeal process? So, but we do work closely with our managed care team.
Good.
I see a follow-up to the KPI question. Tony, I'm going to direct this one to you just so we make sure we close that loop. Someone asked, what would be a healthy cost-to-collect ratio?
Well, I will tell you, there's a lot of debate on that. There's some national standards with that. And Jonathan maybe wants to share some of those national standards, but sure. I know there's a lot of debate internally as to where that falls.
Yeah, I think it's a function of the formula, right? Like, what are you counting? And I'm a kitchen sink guy. And I was a big bad finance guy. I think you would have hated me, Tony. But, if I'm cutting a check, that goes in my cost to collect number, right? So if I'm paying my staff a paycheck, if I'm paying my eligibility partner, my estimation person, that goes into that cost to collect number. And HFMA has got some pretty good metrics out there. I'm happy to share FinThrive's definition. We've got one. I think there's other ones. I think it's going to vary to Tony's point from debate on what goes in. Do you put the encoder in there? Do merchant terminals, the things that you swipe the credit cards in, count or not? Again, if I was writing a check and it hit my cost center, I counted it. That's kind of my advice. You can talk to your VP of revenue cycle, or if you are one, if it's hitting your P&L and your operational statements and monthly, then it counts. As far as industry standards go, HBI, I'm a big fan of Health Business Insights. We don't get any money from them. We're customers of theirs as well. I use it at my hospital. They track that stuff. It was hovering around 3-4% during COVID. It's dipping down to 2% now, and that math problem they've got a definition for too. But it's basically how much money do you collect and how much did you spend collecting it? So another way of looking at that number is I spend $2 on every 100 I collect, right? If you're running 2%. And you can try to make it as simple as you can, I guess would be my advice. And that would be my advice, Tony, for you as well. If it's not a number that's known is, you know, if you were spending 10, 15, $20 to get at, you kind of look at it like an ATM fee. That's the analogy I like to use a lot. When you go out of town and you're kind of using a non-bank ATM, and you're like, holy crap, they're charging me $5 to take out 20. That's too much, right? So if your cost to collect starts to approach that threshold where you don't really care if it's $1 or $2, you know, coming out. If it starts to get to 3, 4, 5, 6, 7 double-digit percentages, you need to look at consolidating your revenue cycle and understanding how you're going to rethink your revenue management, what that looks like. My hospital had 26 different systems. I don't know how many Memorial Hermann has. I'll bet it's in the 20s to 40s. And I'll bet there's people talking every day about how do we get that number down to something that's more manageable to get it cost to collect. Memorial Hermann's measuring it. They're measuring it to understand juice from squeeze, spend to yield, right? And that would be my take on that. But 2% is best practice, I believe. If you're running 3, that's probably okay. If you're running 5, 6 to 10, that's probably not, would be my advice. And Tony, I don't know if you have anything to add, but that's how I look at it.
No, that was excellent, Jonathan. Thank you.
You bet.
We have a few minutes left, so I'm just going to jam in one more question. Someone in the audience asked, what are your opinions on the upcoming requirements for value-based / performance-based contracts, and who needs to take more risk between payers and providers to make it work?
My first book, and Tony, I'll be interested to hear what Memorial Hermann's at. I'll be brief. My first book said that value-based care is a 2-year-old pooping in its diaper holding a temper tantrum. That's a quote. So it means it's born and it's here and it's going to be raised into an adult someday, but it's still early. I think less than 1 in 5 hospitals have 100% risk on their overall global contracts. I'll be interested to hear where Memorial Hermann's at. We had many pay-for-performance or P4P contracts with select payers, and I'm understanding that it's easier to play ball with some than others. My assumption, and Tony and I, we usually agree on things. We might not on this one, so I'll be interested to hear her thoughts. My opinion is that hospitals need to assume more risk. I think the more that fee-for-service exists and we're episodic in nature, like I can get paid the same amount if I do 5 MRIs versus the 1 that mattered, or keeping a patient in the hospital each day, 8-9 days, not that happens, versus getting paid for the job, not the hour. Those types of things I think will help overall cost and delivery of care. Where we get stuck is agreeing on that payment that is representative of what a health system or a hospital needs. And so most CFOs and revenue cycle leaders that I've talked to are hesitant to engage in those agreements. Sometimes it's out of greed. I'll call a spade a spade. Sometimes it's just out of concern and viability for the future to make sure that they can keep their doors open based off where they're at. Tony, I don't know if you have something to add, but that's where I'm at. I think it's going to take some time. We're looking at years, not months, and probably we won't see a lot of value-based care before a lot of us retire, in my opinion. It's certainly where we want to go, but it's moving much slower.
Jonathan, I probably disagree with a little bit of that.
Yep, I thought you might.
I think it's the fear of really the future and the viability of it and the sustainability of it. I do think it's new. But I also think this may be just a great topic for another session where we could get
absolutely another webinar. I'd love it. That'd be great.
Definitely.
Yeah.
Yeah, and perfect segue. That's all the time we have for today. I want to thank Jonathan and Tony for an excellent presentation and Thrive for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and fill out the post-webinar survey. Thank you for joining us today. We hope you all have a wonderful afternoon.